Well, welcome everybody. My name is Sean Lydon, and I want to welcome everybody to our late-breaking clinical trials session, our live stream. Before we start, I'd like to take a minute to talk a little bit about what VIVA Physicians is. First of all, we're not-for-profit. We're a 501c3 organization, and we're dedicated to advancing the field of vascular medicine and intervention through education, research, advocacy, and multidisciplinary collaboration. We sponsor the annual VIVA meetings and the VEINS conference. Who are we as a board? So we have 3 new members I'd really like to call out: Aaron Armstrong, Vanita Chandra, and Maureen Coey. We also have Josh Beckman, Tony Doss, John Kaufman, Raghu Kaluri, John Laird, myself, Chris Metzger, Krishna Roka Singh, Kenny Rosenfeld, Sahar Sabri, Peter Schneider, and Nitin Singh. The VIVA Conference is a global education course for vascular medicine and intervention. We have an 18-year history now of multidisciplinary education. It's one of our hallmarks. We've always had the luxury of having global live cases. We've excelled at having late-breaking clinical trial presentations, didactic sessions by our leading experts, hands-on innovation labs, multiple theaters with learning formats, and we've been proud to always have great interaction discussion with both people from the FDA and CMS. The VEINS conference has been existing for 10 years, and we've now had a partnership for the last 3, and it's offering multidisciplinary symposium dedicated to diagnosis, intervention, and management of a wide array of venous disorders. And it's now 3 full days of sessions that covers everything from the fundamentals of venous disease to the toughest cases, offering innovative learning for specialists at every stage of their clinical practice. Part of a not-for-profit is we have a mission, and we work a lot on advocacy. We've done a lot with both CMS and FDA on vascular care. We've hosted leaders forums to discuss issues on carotid disease, critical limb ischemia, and most recently, paclitaxel. We have a great collaboration with the LINK course in Leipzig, both with us hosting sessions at their meeting, and they're doing the same for us. In research, our most recent publication was a patient-level meta-analysis of drug-coated devices done with a lot of input by the FDA. The VIVA Reality Trial, which is a study of directional atherectomy at DCB, and we hope to present the 1-year results at our meeting this fall. And the PAD calcium scoring project, looking at how to better score calcium. We've done scholarship grants in conjunction with the American Heart Association. We've recently put in a lot of support to help finish the BEST CLI trial. And we've also supported a CLI registry with the Duke Clinical Research Institute. And as everybody knows, we've worked with the FDA to create objective performance goals for both SFA and renal intervention. We try to recognize leaders and pioneers in the rising stars with both our live, Atlas, VEINS, and VIVA Career Advancement Awards. Our late-breaking clinical trials panel now, I'm going to have them come up to introduce who are experts here to be with us. As always, we try to be multidisciplinary. We have Dr. Maureen Coey, who is the head of interventional radiology at UCSF and our newest board member. Dr. Josh Beckman, a vascular medicine expert at Vanderbilt University. Dr. Gary Ansel, an interventional cardiologist from Riverside Hospital at Ohio Health. And lastly, having someone from regulatory, Dr. Misty Malone from the FDA. I think we have a fantastic session here today with 5 leading clinical trials. We had a lot of great submissions, and the top 5 that were picked based on scientific merit actually all fall along the theme of drug-coated therapies in lower extremity disease. With that being said, I'd like to, with no further ado, bring up our first presenter. It's Dr. William Gray, who's the system chief at Lakanal Health and just outside of the Philadelphia, Pennsylvania area. And he's going to talk to us about the safety and efficacy of Stellarex DCB with low-dose paclitaxel.
Sean, thanks very much. It's really terrific to be here and an honor to present these data on behalf of Professor Henrik Schroeder and the ILLUMENATE EU RCT investigators. Just to review, the Stellarex DCB design goals were to limit drug dose and to limit drug loss while achieving a high drug transfer and high deliverability along with clinical performance. This was done by combining both amorphous paclitaxel with crystalline paclitaxel, which allowed both prompt availability as well as optimized tissue residency. This was combined with an excipient, polyethylene glycol, which allowed for better durability during handling, tracking, and inflation, and slow dissolution to protect from loss on transit to the target site. It also helped keep the target dose low. The Stellarex clinical program is actually a fairly robust program, 9 studies. The ILLUMENATE trials all have met their primary safety and efficacy endpoints, and there are over 2,300 patients treated with the Stellarex above-the-knee DCB trials with independent adjudication for all events. You can see here we're going to speak specifically about the ILLUMENATE EU RCT. The study design is listed here. Almost 300 patients at 18 European sites enrolled between 2012 and 2015 with anticipated 5-year follow-up. Randomization was 3-to-1 unbalanced, and predilation was mandatory. And as I mentioned before, all results were adjudicated by independent core labs as well as clinical events committee and data safety monitoring boards. The 1- and 2-year data have already been published for this trial. Just to review, the 3-year data is listed here in a Kaplan-Meier analysis, and there was a statistically significant improvement maintained over the course of 3 years as compared to PTA with the use of Stellarex balloon. This is the consort diagram for the ILLUMENATE EU RCT. You can see that we started with 294 patients, again randomized 3-to-1. About 35 dropped out before they even entered randomization because of extensive dissection. You can see that the dropout both by loss to follow-up as well as death and withdrawal. And so for this analysis, the cohort group is 151 patients in the treatment arm and 51 patients in the control arm. But you will see in a moment that the vital statistics, specifically death, in these determination of death or mortality is much higher. Baseline characteristics for the groups are listed here. Both in patient characteristics and lesion characteristics, there were no significant differences. I point out that there were over a third of these patients who were diabetic, and about 20% of them have chronic total occlusions with a lesion length of approximately 7 centimeters. Here's the data for the outcomes in the ILLUMENATE EU trial, the 4-year safety, mortality, and efficacy chart. The composite safety endpoint, freedom from all endpoints, was 66% in the Stellarex group and 62% in the PTA group with no statistically significant difference. All-cause mortality, an important highlighted issue these days, was not found to be different between the two groups of 4 years, nor was cardiovascular mortality. Efficacy endpoints are listed here, about a 5% advantage to the Stellarex group, which did not meet statistical significance. And if you look at total cumulative target lesion revascularization at 4 years, about a 10% difference, again, not reaching statistical significance. As I mentioned before, we have excellent data follow-up on vital status on all these patients. So we have almost 94% compliance for vital status determination. And if we look at that through 12, 24, 36, and 48 months, we can see that at the 48-month mark, there is no statistically significant difference between mortality in the two groups. That's displayed here in a Kaplan-Meier analysis. And you can see that there's really no jog in the analysis. It's quite overlapped, and the confidence intervals are merged. If we look now at the ILLUMENATE EU and its sister trial, the ILLUMENATE pivotal trial in the U.S., we can see that among almost 600 patients, there are no statistically significant differences between mortality in either trial. And this really recapitulates a publication we had last year which combine these pivotal and new RCTs. On the left, you can see the Kaplan-Meier analysis of that combined data set, and there was no statistically significant difference between their mortalities. And I already showed you this slide, this chart on the right. So in conclusion, the ILLUMENATE EU RCT all-cause mortality rates between Stellarex and DCB, Stellarex DCB and PTA continue to be similar out to 4 years. ILLUMENATE EU RCT is the second Stellarex RCT to consistently show no statistically significant difference in long-term all-cause mortality with annual follow-up, at all annual follow-ups out to 4 years. And the 4-year data continue to show favorable overall safety and efficacy of Stellarex low-dose paclitaxel DCB. Thank you very much.
Thank you, Bill. That's some great data. Why don't I open it up to our panel for questions to direct to Dr. Gray. So Dr. Ansel, I know you helped lead our Vascular Leaders Forum a year and a half ago on paclitaxel. How does this data fill into the gaps we started with a year and a half ago?
Well, first, congratulations, Bill, and to Phillips on getting your 4-year data. That's awesome. And I think that one of the things that it shows us is that we're not seeing a consistent mortality signal across all the different studies, which, again, leads us to wonder if this is just an association or causative. Bill, the one thing I did have that wasn't presented is the time to first revascularization on that trial, now that you've got 4-year data. Do you have that kind of result, or do you have that? Because certainly it looks like there's a lot of difference between the drug-coated balloon and the plain balloon angioplasty as to the time when the patient first has to have a repeat procedure.
Well, I'm not sure I understand, Gary. What did you want to know?
So if somebody gets treated at time 0 with a drug-coated balloon or a plain balloon, what's the average time to a repeat procedure? Is the drug really having an effect? I mean, it might be catch up at 4 or 5 years, but what does that mean to the patient who's actually being treated?
Right. I don't have the data, but I understand the question. There is a delay in revascularization as compared to PTA, but I don't have that number for you.
Is the trend in the same direction in the American data as the EU data, or a favorable direction, if not statistical significance, for reduced secondary procedures and restenosis, things like that?
The U.S. data looks very similar. There's actually a little bit broader difference between PTA and DCB in the U.S. data. You'll recall that IMPACT actually had a very similar phenomenon where at 4 years it came together to about a 7% difference between the two groups. Here it's about a 5% difference, and then it widened again to about 10% at 5 years. I think that when we get to these later timelines, our field of vision gets a little bit broader, and the numbers also get a little bit smaller, and so it becomes more difficult to discern some of the effectiveness data sets.
So, Dr. Malone, how does the FDA then, work this later data into the original analysis that the FDA did, and then the recent update that VIVA just put out on patient-level data from the drug-coated trials?
That's a good question. And I want to start off, Gary, you actually asked the question I wanted to ask regarding the time to event. So I look forward if we can evaluate that, because I know that's when we reevaluate this data, one thing we're interested in is weighing mortality with benefit and signal. As more data comes available, we don't want to reevaluate the signal over and over and over. So we're looking ahead to the future when there's enough data available that we can effectively reevaluate the signal using robust, high-quality data. So we take this into consideration, and we appreciate opportunities like this to hear the latest trials and hear discussion. And I would be interested one day speaking with you and other clinicians regarding this time-to-event analysis and if it's and the value.
Bill, I had a question. With regards to the PTA arm, those individuals did not undergo any sort of drug-eluting intervention on the other limb, I presume, right? Or would we know?
Not known. There are actually Phillips has done a pretty good job of going to try to figure out what happened with the restenotic crossover, and in that way presented to the FDA last year. There was about a 20 to 22% crossover in the index lesion, but we don't have a lot of data on either prior treatment before the study or contralateral treatment. So you ask the right question, because the issue is really paclitaxel exposure, and if we're positing that that's a causative agent, we need to know what the total exposure would be.
Well, that's great, Bill. I really want to thank you for presenting to us this awesome new data. And I'm sure as it comes out in press, people will be really excited to dig through all those data sets. So I'd like to now switch gears to bring up our next speaker. And so our next speaker is Dr. Frank Vermassen, and he is going to win the award for the champion of the night. He will not be our presenter from the farthest away, but he'll be the presenter who's up the latest. He's going to be presenting us from Belgium, and he's going to talk to us today about the 2-year outcomes for Eluvia in long lesions, the IMPERIAL long lesion sub-study. And so if we can go over to Dr. Vermassen, who's hopefully going to talk to us from across the pond.
Hello, Sean. Yes, thanks for the introduction. I want to start sending you greetings from Europe, indeed, and I hope you're all doing well. What I want to present you tonight are indeed the 2-year outcomes of the Eluvia stent in long lesions, and more specifically, these are the results of the long lesion sub-study of the IMPERIAL trial. These are my disclosures. Oops. Yes. The Eluvia stent system actually obtained a CE mark in 2016 and FDA approval in 2018, and is based on the DeNova stent platform. It's a self-expanding nitinol stent coated with biostable polymer matrix and coated with a low-dose paclitaxel. In fact, the dose of paclitaxel on this stent is far lower than what's normally used for drug-coated balloons or for the competing drug-eluting stents. It's delivered through 6 French triaxial stent delivery system, which is 0035 guidewire compatible. The main study in the IMPERIAL clinical trial was actually a head-to-head randomized comparison between the Eluvia stent and the Silver PTX stent. This study, of which the results at 1 and 2 years are published already, showed a significant improvement in clinically driven target lesion revascularization at 1 and 2 years for the Eluvia stent compared to the Silver PTX. But what we are going to present now are the results of the sub-study in long lesions. In the main study, actually, the lesion length was limited to 140 millimeters, and in the sub-study for lungs, these were lesions between 14 and 19 millimeters. Of the 50 patients that were included, actually 43 completed this 2-year clinical visit, and these are the results which I'm going to present. The mean lesion length was actually 16 centimeters, which is far longer than what's normally seen in most DCB trials, and almost 3/4 of the patients had moderate to severe calcifications. About 1/3 of the patients also were total occlusions. The safety of the device was shown and proven by the fact that the clinically driven TLR rate was 13.6%, and the number of stent fractures was only 2%. The death rate, by the way, was only 4% at 2 years, which is also very low. When performing a Kaplan-Meier analysis, we see that the freedom from clinically driven target lesion revascularization through 24 months was 86.7%, which is actually among the best results which are obtained with any device in this region, and certainly for these long lesions. The same can be said about the primary patency rate at 24 months, which is 77.2%. These excellent results were also true with regard to the clinical outcomes. As you can see, 88% of the patients improved by at least one category at Rutherford class without the need for target lesion revascularization. And only 5 out of these 42 patients had no or minimal symptoms at 24 months. The same is true with regard to the walking impairment questionnaire. There is a consistent and sustained significant improvement in walking impairment from baseline at 24 months. In the IMPERIAL trial itself, it was already shown that also in more challenging lesions, such as calcified lesions, diabetic patients, and in patients with total occlusions, the results are actually about the same as in the main subgroup. And now we can also add the lung lesions to that analysis, showing that also in the lung lesions, the results are actually very comparable to the ones which were obtained in the total group. So, dear friends, as a conclusion, I think we can say that despite the complexity of the lung lesions and of the lesions in this trial, the patients treated with the Eluvia in this sub-study of the IMPERIAL trial showed excellent results with an almost 87% freedom from clinically driven TLR, 77% primary patency, a consistent and sustained significant clinical outcome improvement, and a good safety profile. The results observed in the IMPERIAL lung lesion sub-study and also in all study subgroups demonstrate consistently lower intervention rates among patients with more complex characteristics. Thank you for your attention.
We'll go ahead and open that up to questions to our panel again.
So I'll start off if it's okay again. Frank, excellent presentation. It's awesome data that we're getting because these are the real world lesions that we're really treating every day, not the short things that we get into IDE trials. And so, I mean, this is really excellent data showing both decreased clinical retreatment as well as high patency. But there's still a disconnect because not all the restenoses are being retreated. Do you think, or have you guys looked at the pattern of restenosis? Because I know with Zilver PTX, there was some evidence that it was less, the restenosis was less diffuse. Have you guys been seeing the same thing?
Well, I don't have the precise data with regard to that characteristic at the moment, but what can be said, anyways, by the way, there were no other revascularizations except the ones that were clinically driven. So that's already a point to be taken. And as for the rest, well, what we see in the, what you do actually is a comparison between between drug-eluting stents and plain balloon angioplasty. And it's true that it's a general observation that after these stentings, indeed, the restenosis, if we see them, are indeed less severe in this group which is stented, and therefore maybe indeed less symptomatic.
Dr. Beckman, you want to unmute your microphone? No, we still can't hear. How about we go to Dr. Cohey? I see she's got a comment.
Thank you. I was just trying to help out Josh there. Excellent demonstration of results. I agree with Gary that these are the challenging cases that we don't usually find in the primary trials. Could you tell us and the audience the different kind of interventions, if any, that you did prior to stent deployment, and what do you do in your practice with respect to IVUS or atherectomy or any of those interventions?
No, there were no atherectomies in this study. So there was, in the study protocol, it was forbidden. So this was just pre-dilatation and then stenting with the drug-eluting stent.
Can you guys hear me now?
We can.
Awesome. Yep.
I'm sorry for that, but now I can get to ask a question. I was very impressed by the walking improvement that you showed. Was there a relationship between the clinically driven requirement for revascularization and the change in walking?
Well, clinically driven target lesion revascularization they were all done for those conditions which showed a more than 50% restenosis combined with decrease in walking distance or return of clinical symptoms or a significant decrease in ABI or TBI.
Okay.
Dr. Malone, thoughts or questions?
I was curious if in Europe there are any other patient preference surveys that you typically use. I saw the walking impairment. Were there any other patient preference studies done? Or not patient preference, sorry, patient-reported outcomes. I've got patient preference on my mind.
Yeah, patient preference is not done in the walking impairment questionnaire either. In this study, the walking impairment questionnaire was predominantly used. In some of the studies, of course, EQ5D is often used also with to analyze the patient-specific, clinical improvement.
So that's really fantastic data. I want to thank you for bringing this data to us, and I'd like just to reiterate what the rest of the panel said. It's really good to start seeing the real world patients that we treat on a daily basis to sort of see how they came out in a randomized trial. And then lastly, I want to thank you for presenting this to us, because for those of you guys who don't realize, Belgium, it's now almost 2 o'clock in the morning, and so he definitely gets our hero award for the A above beyond effort to present to us. So thank you very much. So with that, we'll go now to our next presenter, Eric Secemsky, who is going to be coming to us. He's at the Beth Israel Deaconess Medical Center, and he's going to bring us some more real-world data as he talks to us about the long-term safety of paclitaxel drug-coated devices and peripheral revascularization and analysis from the Optum Medicare Advantage cohort. And so we'll now once again get to really continue to see the real-world cohort.
Great. Thank you, Sean, and thank you, colleagues, for inviting me to give this presentation. It's just about 8 p.m. here, so I can't take any hero credit on this one. But I'll be presenting the analysis of the Optum Medicare Advantage cohort. Some of these results were already seen at the FDA panel, and this is the final analysis of that data set. I want to just recognize that this report and analysis was done in partnership with Medtronic, and I want to thank all of my colleagues who assisted in the analysis, as well as my co-investigator, Dr. Robert Ye. So everybody here is familiar with the meta-analysis from December 2018, which first demonstrated in a peer-reviewed publication harm associated with paclitaxel coated devices. Again, when we looked at the 4 to 5 year data in the original analysis, this was just of 3 studies of 863 patients and demonstrated about a 6.5% increased risk of harm. Now, as a follow-up to this, we shortly completed a first look at Medicare data. On the left here was a publication in JAMA Cardiology looking at inpatient data for patients who underwent drug-coated devices with 600 days of follow-up. On the right here is a publication in JACC looking at only at patients who had drug-eluting stent, primarily the Zilver stent, just based on timing and approval, and again, showed no evidence of harm through 1,440 days of follow-up. And at the FDA panel, we prepared a larger analysis of Medicare fee-for-service beneficiaries. This totaled over 152,000 patients at more than 3,000 institutions throughout the US, and over a median of 800 days, and as long as 1,500 days, we showed no evidence of harm associated with drug-coated devices. Now, interesting, Medicare has changed a lot in the recent years. There is both the fee-for-service group and then also the Medicare Advantage group. And we call the Medicare Advantage group the private plan alternative. So in our initial Medicare analysis, we did not include any of the patient data that I'm about to show you now. And Medicare Advantage represents just over 1/3 of all Medicare enrollees. So these are new patients not included in those prior analyses. And it's notable that patients who enroll in Medicare Advantage often have higher self-reported health status, cognitive impairment, and better functional impairment. So these tend to be a healthier subgroup of the overall Medicare group. Now, this analysis was pre-specified. It was designed and protocol reviewed by the FDA before it was implemented. So everything was already pre-designed when we were blinded to the outcome when we performed the analysis. This was of the Optum's de-identified clinical informatics data bar database. So this is a large data set, and we focused on Medicare Advantage patients who underwent revascularization between April 2015 and December 2017, relying both on ICD-10 and CPT coding. We looked at treatment exposure based on whether a drug-eluting device was used or a non-coded device. And we looked at a look-back of 3-month period to ascertain comorbidities, as well as look at cardiovascular medications that patients were taking at the time of their procedure. Similar to our prior analyses, we looked at all-cause mortality as a primary outcome, which was ascertained through December 31st, 2019, so pretty contemporary. And we used the inverse probability of treatment weighting to create balance between groups treated with either drug-coded or non-drug-coded groups. So this is a way to control for imbalances in characteristics. And we performed a number of pre-specified, again, these were all noted in our analytic plan before we undertook this analysis, groups that we thought were of notable importance, both looking at device type, PAD severity, place of service, sex, age, and comorbidity burden. So this is the data set that we examined. It was just under 17,000 patients. I'll note that the average age was 73. And again, this is about 3.5 years younger than the average age in the larger Medicare fee-for-service population. Of these patients, 44% were female, about 11% had a prior amputation, and just under 60% were smokers. And notably, about 63% of these procedures were outpatient procedures, so what we tend to think of lower risk setting for procedure revascularization. Lastly, just under a third had been using a P2Y12 inhibitor at the time of the procedure, and just about half a statin. Now, this is the pre-weighting characteristics. So here we have both patients who've got non-drug-coated devices and drug-coated devices, and we want the standardized difference to be less than 10%. And you can see here, before we adjust, we have a few characteristics that are imbalanced. Well, there's more atherectomy used with drug-coated devices and also more P2Y12 inhibitor use. After application of our weights, we now see well balanced across all characteristics, in particular atherectomy and P2Y12 inhibitors. And when we look at this in a plot, again, orange here is post-weighting, blue here is pre-weighting, and at the top you see these outliers. Those are imbalanced, and after application of the weights, we see nicely that all groups have very similar characteristics before we do our analysis. Now, at this point, we've never looked at outcome, and now once this was set, we then unblinded, and looked at the outcome so that we were not able to see treatment ascertainment before the outcome. So this is the total population. There's a median of 2.66 years of follow-up. Patients were followed as far out as 4.75 years. Just over 20% had a drug-coated balloon and about 5% a drug-eluting stent. And in this analysis, we again found no evidence of harm associated with drug-coated devices, again, with the longest follow-up out past 1,700 days or more than 4.5 years. In the red here is drug, and the blue here is non-drug. These are weighted figures here, an adjusted hazard ratio of 1.03 with a confidence interval of 0.96 to 1.10. So no evidence of harm through 1,700 days. When we break this down by the balloon angioplasty cohort, about 38% of this cohort had a drug-coated balloon. Again, we look here, red is drug-coated balloon, blue is uncoated balloon. We found no evidence of harm with a hazard ratio of 1.0 through this long period of follow-up. And similarly, when we look at the drug-eluting stent cohort, which is primarily the Zilver PTX due to the timing of this analysis, we found no evidence of harm through 1,700 days of follow-up. Now, you'll notice on all of these high mortality rates, these are still Medicare patients, but these are the correct mortality rates. These are based on Medicare mortality data, and it shows you how really severe this process is. I want to point out some really important pre-specified subgroups. Here we look at a number of characteristics, age, and we're looking at some of these Medicare patients who are under the age of 64, some are in the middle of 65 to 74 and 75. We found no evidence of harm by age. We found no evidence of harm between different sexes. as well as between CLI and the claudicants or non-CLI group. We also show no evidence of harm whether we break up by procedural location, inpatient or outpatient, or if we look at different comorbidity terciles. So this was an important question at the panel, was whether low comorbid patients might have less competing risks and more evidence of mortality, and we did not find any difference based on how many comorbidities you had in this analysis. So I want to summarize our findings from the Optum Medicare Advantage analysis. Again, we conclude that through 2.66 years of median follow-up and over 4 years of follow-up in total, we found no evidence of harm associated with these devices. And again, this was not found in important subgroup analyses that we looked at as a pre-specified basis. And we're continuing this work, as everybody's probably familiar with, in the SAFE PAD study, which was also designed with FDA input, and we'll continue to follow the population of fee-for-service Medicare beneficiaries, and we will continue this analysis as well to make sure that we find no evidence of harm as patients move forward with their follow-up. Thank you very much.
So Eric, congratulations. That's just outstanding. And I want to thank you for doing this important work. And I'd like to start off with the first question. You know, having been at the panel and at the VLF we did on this topic, a lot of the original discussion with your prior publications were, you know, how well the Medicare cohort correlated to what we see in the randomized trial data. And there was always concern that the Medicare data population, because of CLI and age, had a sicker population, and that it may be blending the differences. And I think it's amazing that you're now showing that with similar lesser comorbidities and no CLI, there's no difference. How pared down does the population get when you're starting to look at those differences, and then how much more can this data set be expanded to really sort of add weight to that finding that it's similar to the clinical trial population we see in the randomized data sets?
Yeah, great question, Sean. You know, the nice thing about these data sets are we have 17,000 patients. So when you do look at subsets of patients, it's not on the order of 100 patients like we've seen in the original meta-analysis. We still have thousands of patients that we're examining. So I think that, you know, this is really critical component of this analysis, is that it's a younger population. And like you said, Sean, that it's less comorbid, and this is brought up. And I think that there's a lot of opportunity to further the analysis of this data set to answer some of these key questions. Again, this is an opportunity where we had Medicare data, medication data at the time of the procedure. And so we were able to look at that in future analysis as well. But, you know, I think as we continue to see more and more real-world data that's of high quality in large numbers, we've failed to represent this signal over and over again. I think it's time for us to really take these findings and start to weigh them a little bit more equally.
So how about questions from our...
Eric, when you end up submitting this for publication, are you going to include a falsification endpoint just to further demonstrate that there's no real confounding from this as an observational cohort?
Yeah, wonderful question, Josh. Very ahead of the game there. You know, we made a pre-specified analysis right when the safety panel had ended with the FDA, and so we followed it by the book. And so hopefully Misty knows the protocol, but so that was not pre-specified at the time as part of that analysis, and we really didn't want to deviate from that. And again, we were very particular. We had no evidence. We had no idea who had what outcome when we built this data set. So that's incredibly important to be blinded to the outcome when we built this data set. We followed that protocol to the T. So the next round of data that's going to be coming from SAFE PAD has multiple types of analyses like that, including the falsification endpoint. We spent a lot of time kind of discussing that in the methods paper that is under review, and then also you'll be seeing that publication in the near future.
So excellent, Eric. I mean, this is the kind of data we really need to get. And I guess I'm really happy that there's a collaboration between you guys and FDA, because I'm a little concerned that what happened with carotids is going to happen to the SFA, because industry is going to walk away from this vascular bed unless we get this answer. Is there a feeling, or Misty, if you can address this, is there a feeling about how much data is it going to take? Is there behind a room, a closed door, that says, listen, we get tens and almost 100,000 patients, and we don't see any signal, and we've got it split and diced every way we can? When does this override the small populations from the ID trials that are prone to getting outliers and things like that. I mean, I'm really concerned because certainly CROD wasn't due to FDA. It was, it was our fault. But this is now, we as an industry, along with regulatory, have to work in a partnership. Misty, what's it going to take?
I was curious if Eric had an answer to that. I think there's going to be a lot of data coming up soon, so I'm hoping it doesn't take long. I mean, I appreciate PIs like Eric looking into this, and I wanted to ask him if there were any lessons he learned from the analysis that he did last year and this analysis and moving into Safe PAD. In order, if we ever have signals like this in the future, what would you tell people in the future to do?
It's a great question, Misty. I think, this is the one time where we've really been tested like this and had the opportunity to look at real world data. So I think that we've learned a lot, and I think we are going to be better prepared moving forward. And as we understand these data more, we've learned more about how to approach the analyses. So I think preparation here is really key and experience. And I think we're hoping to set a precedent where inevitably this will come up again, that we're able to respond in a very quick and organized fashion.
So final question, Dr. Cohey.
Yeah, just more of a comment. So really congratulations on this study. I think what I took away from this is, real world data, real Medicare, large number, and you can see that you have 44% women in your subgroup. And I think that really does substantiate the fact that we need more women in our primary ID clinical trials if we want to make accurate assessments of outcomes, long-term outcomes, mortality outcomes, when it comes to the general population. So well done.
Well, I want to thank you, Eric, for great paper and bringing this to us. And I think it continues to build on the data set. And I also just, having the partnership with you and the FDA to sort of look at this has really brought really great data to us. So we'll let you go, and we're going to bring on our next presenter. And so our next presenter is going to be Dr. Patrick Geraghty, who comes to us from Washington University in St. Louis. And he's going to talk to us about the TOBA II BTK 12-month data results. So Dr. Geraghty.
Super. Well, thank you very much to the VIVA board and to all of our team at Intact Vascular, all of our investigators. It's a pleasure to be able to report the 12-month results for TOBA II BTK. As we're aware, the chronic limb-threatening ischemia is a very serious problem affecting millions of people in the US. The treatment of the below-knee arteries for chronic limb-threatening ischemia remains centrally based on angioplasty. Dissection is a common occurrence. It occurs frequently, and it also predicts a restenosis and poorer outcomes across these groups. So the optimal treatment of dissection in the below-knee arteries is critical to optimal outcomes. The TAC4 French endovascular system is basically the 6 French system writ small for the use below the knee. It also contains 4 preloaded nitinol implants. These are 6 millimeters in length when deployed. They self-size from 1.5 to 4.5 millimeters for reference vessel diameter, and they maintain a fairly low and flat outer pressure as they self-size across there. It's an over-the-wire delivery system, again, 4 French compatible, 150 centimeters working length with very accurate pin and pull deployment. This is part of a large body of evidence that's been accumulated for the TAC device, both above and below the knee. This table demonstrates the 3 above-knee studies in the dark blue, followed by the small single-arm study, the TOBA BTK, and then the current pivotal trial, which we're reporting. The 6-month results were already reported at the VIVA meeting in 2019. You see some of the excellent results there, 92% freedom from CDTLR, almost 96% amputation-free survival, good wound healing, very low bailout stent rate, and 100% resolution of dissections at the acute treatment. This is the study design. This is a prospective single-arm pivotal IDE study. Because of the lack of an on-label scaffold to compare against, this was compared against objective performance guidelines or goals that were derived from the literature. We enrolled 233 patients. Each of these had experienced a post-angioplasty dissection during the course of treatment of the mid-distal popliteal, tibial, and peroneal arteries. The primary endpoints for safety was major adverse limb events and peri-procedural death at 30 days. Efficacy was freedom from major adverse limb events out to 6 months with the addition of peri-procedural death. Secondary endpoints were TAC segment patency through 6 months and target limb salvage at 6 months. Additionally, we looked at multiple observational endpoints, including dissection resolution, freedom from clinically driven TLR, target lesion patency, amputation-free survival, and changes from baseline status in Rutherford class, wound status, and quality of life questionnaires. On the right, we see the cartoon here demonstrating the enrollment and follow through to 12 months. At the 12 months of our original 233 patients enrolled, we had 24 patients who missed that visit but may still make later follow-up visits. 29 have terminated the study due to death, withdrawal, and other reasons. Again, I'd like to thank our investigators, my co-investigators, Dr. George Adams and Dr. Andre Schmidt, and our multiple investigators both in the US and internationally. At the bottom of the screen, you see our core lab angiography was from the Yale Cardiovascular Research Group and the VAST core lab group for duplex ultrasound analysis. So here's the patients who were enrolled. Average age was 74 years, about 2/3 male. Rutherford class, 16% were claudicants and 3, 84% chronic limb-threatening ischemia, Rutherford 4 and 5, with 50% having tissue loss at presentation. The usual suspects in terms of comorbidities for smoking, presence of diabetes, presence of previously treated coronary atherosclerosis, renal insufficiency. On the right side, we see lesion characteristics, reference vessel diameters, both proximally and distally for the treated vessels. Baseline lesion length, the investigators favored the use of longer balloons, which is why there's a bit of discrepancy between the core lesion length and the actual angioplasty treated length that was performed. Almost 50% of the lesions were chronic total occlusions that underwent treatment. Calcium, for the most part, was mild to moderate. The target vessels are noted here, distal pop through the tibial vessels. This trial did not enroll treatment of inframalleolar vessels. Distal delivery was excellent. We treated an average of 1.4 dissections per patient. Here we show the distribution of the NHLBI dissection grades. Very low bailout rates. Dissect device success was excellent. The average TACs per patient were 4 TACs per patient. The cartoon on the right shows the distribution of the TACs deployed. And I would draw your attention to the fact that 1/3 of the TAC implants were deployed in the mid to distal tibials, not an area where we're used to deploying scaffolds. At 12 months by X-ray follow-up, there was 0% fracture, migration, or embolization. Here's a brief review of the 6-month primary and secondary endpoints. Again, these were compared to objective performance goals, so the confidence interval should fall within the objective performance goal to meet the goal, and in each case for the primary safety, well within the objective performance goal of 12%. For the primary efficacy, we had a freedom from major adverse limb events at 6 months and 30-day post-procedural death that was well within the performance goal of 74%. Likewise, the TAC segment patency was well within the patency goal. And we also addressed an unpowered 6-month target limb salvage. Looking now at the 12-month outcomes, we see the TAC segment patency at 81% at 12 months. Slightly behind is the overall target lesion patency because the target lesion may have extended beyond the TAC segments, but excellent patency out to 12 months. Freedom from loss of patency or clinically driven TLR as we track that together. So, the patency was a open shut duplex or angiographic proof of prograde flow. But we also decided to subtract any clinically driven TLR. I think that's a very relevant endpoint for clinicians. So either the loss of prograde flow or a clinically driven TLR. That was 72% at 1 year. So I think an excellent overall result there. Target limb salvage was excellent. We did not lose any claudicant limbs, a very low limb loss in the chronic limb-threatening ischemia group, 96% salvage through the year. When we look at CDTLR, amputation-free survival was excellent through 1 year. I'm sorry, the CDTLR was excellent through 1 year. Over here on the right, we break down amputation-free survival by all comers and the chronic limb-threatening ischemia with excellent results through 1 year, 89%. Excellent sustained improvements in both TBI, excellent wound healing, 68% healed, the majority either improved or with an amputation that had fully resolved and healed. Again, rate of major amputation quite low at 2%. Sustained improvement in the Rutherford class through 12 months. Navy in the back row is the initial Rutherford class. As we move into the 6 in the lighter blue and rust colored for the 12-month follow-up, we see that sustained improvement in the Rutherford class. And finally, sustained improvement in quality of life across a variety of domains, extending both to 6-month and 12 months. So in conclusion, this is the first BTK vascular implant to achieve FDA approval. It enrolled 100% post-angioplasty dissected vessels. The TAC implant repaired 100% of those dissections on table. At 12 months, we see no fractures, migration, or embolization. 81% of patients show TAC segment patency. 83% of patients were free from CDTLR, and we see sustained improvements across Rutherford class, across hemodynamics, and quality of life domains. Finally, looking specifically at the chronic limb-threatening ischemia populations, we see excellent target limb salvage and amputation-free survival. Thank you very much.
Thank you, Dr. Geraghty. I want to thank you for presenting this great data. And since this is the first vascular implant for the below-the-knee segment, I wanted to give Dr. Malone first crack at her comments and questions on the 12-month data, since we're so excited to actually have an on-label implant for the below-knee segment.
Sure. So I was interested in, congrats on the trials and the excellent data, especially in the below-the-knee patient population who need to be treated here. I'm really amazed by wound healing and all the measures that you showed. I was curious how you use the device in your practice as opposed to angioplasty or stenting, or if you use this device somewhere in between.
So, just come out, and again, the indication is for post-angioplasty dissection repair. So I think a critical point here is that because of the relatively low outward force of the device, it's not something that we use to displace a heavily calcified rock that doesn't respond to initially balloon angioplasty. But if you get a initially satisfactory effacement of the lesion on balloon angioplasty, followed by a dissection flap that may not respond to secondary inflation, this is an excellent, very precise device where you don't necessarily have to carpet the entire length of the dissection. You can place at several different points to tack up the dissection and reassess along the way.
So I'd like to add to that. I've watched my conflicts because I was an investigator in this trial. But Misty, one of the things that's an indirect thing that I think this does is it allows us as operators to get more aggressive with our balloon angioplasty, because now we have an actual device for bailout. And I wonder if that didn't play a role in the really good outcomes here, that we were much more maybe optimal or what we should be for balloon angioplasty, because we had a bailout if we had dissection that now seems to work. It'll be interesting to see how good our results are long term.
Yeah, I think particularly if you talk, sorry, please go ahead.
No, it's okay, go ahead, finish.
I was to say, if you talk to the intravascular ultrasound enthusiasts, they're always commenting on the fact that our balloon angioplastic diameters are so much less than the true vessel diameter that they appreciate. And I think with the ability to bail out with this, it allows us to pursue that serial dilation that gets us up to what should be the true nominal size without fear of losing vessel patency from a dissection in the mid-tibial.
So I wanted to ask my question, again, congratulations, great presentation. In your group, did you see a degree of individuals with heavy calcifications? And if so, did you notice that the degree of calcification prevented the deployment of this device? And any comment with regards to that?
So we didn't have any recorded failures with that. I think certainly the investigators were all made aware, both in the trial protocol and in pre-trial teaching, that, as I mentioned, we weren't trying to use this to displace calcific lesions that didn't respond to the initial angioplasty. But the simple presence of medial calcinosis is no contraindication to this. But I think if you have an eccentric calcific rock, a little popcorn protruding into the lumen that you're not displacing well with initial angioplasty, this is not the device for that. But for tacking up an angioplasty flap in an otherwise medially calcified vessel, it's perfectly suitable.
Dr. Beckman, a closing comment for Dr. Geraghty?
No, I think it's really exciting to have new devices for below the knee. I guess I'll ask just one quick question. Is the post-procedural medical therapy, antithrombotic therapy the same? Or do you think it may need to be different because of its location and the size of these devices?
Currently the same. There's really no great proven cookbook for this, but initial dual antiplatelet and then longer transition to the monotherapy. The struts itself are very thin. So in terms of luminal creep, you're really not losing much. But yes, we kind of followed the same routine cookbook as most of the lower extremity trials.
So thank you very much, Pat. Excellent data. We're very excited to hear some emerging data for 12 months for now available treatments in the below the knee. So we'll switch to our last speaker. So our last speaker is Dr. Jun Tang, who comes to us from the furthest of anywhere. He actually is a senior consultant from the Department of Vascular Surgery in Singapore General Hospital. He's going to talk to us about the first outcomes of the Luminor DCB and TASC and D tibial occlusive disease lesions. So Dr. Tang.
On behalf of the MERLION investigators, I would like to thank the board for giving us the opportunity to give a presentation of our interim results on outcomes using the iVascular Luminor DCB for quite complex tibial below the knee occlusive disease in the setting of chronic limb-threatening ischemia. The challenges in CLTI in our country is that endovascular therapy has now become the first-line option for infrapopliteal arterial occlusions because it's obviously minimally invasive, it's a repeatable procedure, also very much patient and family choice. And in the setting of CLTI, these patients are very frail with multiple comorbidities and are generally ASA grade 3 and 4 when they present to us. And as I will show you, our diabetic population is very high, and there's general surgical conduits for bypass. However, with endovascular therapy, there are problems associated with bare metal stenting and plain angioplasty because of significant recoil because of the calcification that we find in our BTK vessels, and along with neo-intimal hyperplasia. So what we need is a sustained therapy because these wounds typically take us 3 to 6 months to heal on average, and obviously we want to sustain the pulsatile blood flow to the foot. So the diabetic foot challenge is ever increasing in Singapore. The recent OECD data suggests that major lower limb amputation rates are 3 to 4 times higher than in the West, and it's actually increasing despite our best efforts and the new technologies associated with endovascular therapy. So the MERLION trial is basically a broad inclusion, real-life registry, really, basically stands for physician-initiated, prospective, non-randomized, multi-center trial investigating the safety and efficacy of the treatment of the Luminor drug-coated balloon with bailout stenting using their angiolyte drug-eluting stent in TASC and D tibial occlusive disease in the setting of critical limb ischemia. So the Luminor balloon is basically the paclitaxel based balloon with a microcrystalline structure that is basically using nanotechnology to transfer to the wall of the vessel. And the excipient is basically a water-reducing ester. The BTK angiolyte stent is a cobalt chromium stent with a very high radial force. And we only used it in the setting for this study for bailout stenting for bad flow limiting dissections. So the primary objective of this study was basically to evaluate the 12-month outcomes basically of the mono or combination therapy using the iVascular Luminor DCB and angiolyte DES. And basically we only treated TASC and D lesions in the setting of CLTI. These were our study endpoints, the typical peripheral lower limb kind of standpoints, freedom from device or procedure-related mortality through 30 days, clinically driven TLR, as defined by more than 50% restenosis and recurrent symptoms that we go in, freedom from major target lower limb amputation, and duplex defined criteria are primary patency rates at 6 and 12 months. And obviously the technical success and clinical success was documented. We performed this over 2 study sites. The main site was Singapore General Hospital and another hospital in the northwest of the country, 50 patients with tight follow-up. And enrollment was generally over a year from December 2018 to October 2019. Just to give you a flavor of what we do, we basically perform only CLTI major over 90% for limb salvage. We performed 1,200 low limb angioplasty CLTI over the last 18 months. Patients generally present late, with more than 90% being diabetics, more than 50% with renal impairment with multi-level disease. Those were our inclusion criteria. We treated both de novo and post-PTA lesions. Of those with previous restenotic lesions, those were not treated with drug. All vessels had to have at least a distal reconstitution above the ankle, and we treated all inflow disease appropriately with the same balloon, and all had pre-dilatation before enrollment. And this is the enrollment kind of chart showing that we only enrolled if it was angiographic suitable at the time of the procedure, and we followed them up at 1, 6, and 12 months. So turning to results, I want to highlight the patient demographics because I think it really is a contrast to what we normally see in the studies. Our patient demographics, 94% are diabetic, with 50% with end-stage renal failure and on dialysis. In terms of procedural information, the TASC C and D lesions, and I want to say that looking at the calcification as per Datillo's scoring, more than 50% had moderate or severely calcified vessels. Majority were with Rutherford 5 class wounds. And you can see the duration of symptoms are very, very long, over a couple of months. Turning to treatment outcomes at 6 months, we had 100% technical success, 100% freedom from device or procedure-related mortality at 30 days, an impressive amputation-free survival at 86% at 6 months, and a freedom from TLR based on lesions of over 90%. It is a very challenging population. Our target lesion primary patency was 79% at 6 months. In terms of clinical success, you can see that in terms of people in Rutherford class 5, the improvement was at least by down to a quarter, of 82% to 17%. And you can see from the clinical success that there was an improvement of at least 1 Rutherford score in nearly 70% of patients. Just to give you a flavor of what we've been doing, this is a case study of a 52-year-old Chinese male presenting with a non-healing wound with the typical past medical history that we typically encounter every day. The target lesion in this one was an ATA with TASC C with multifocal stenosis. We pre-dilated it and obviously then treated it with a 3mm Luminor. And this is what the result was. Pretty good angiographic result with a residual of less than 30%. This was the pre-op duplex. The duplex generally belies the underlying disease on our duplex and undercause it in general because of the calcification. And this is the 6 month post-op duplex showing a good flow within the ATA with a palpable pulse at clinical follow-up. And that's the wound healing at 3 months, actually healed within 3 months, and it stayed healed at the 6 month follow-up. So in summary, Mr. Chairman, ladies and gentlemen, this MERLION trial is a prospective, non-randomized, single-arm, multi-center from Singapore. We evaluated both safety and efficacy, although at a short time period at 6 months using the iVascular Luminor DCB and Angulite DES. We treated relatively long, complex tibial occlusive disease in the setting of CLTI, 50 patients with tight follow-up with very heavy burden of diabetes and end-stage renal failure. In terms of median lesion, we treated about 14 centimeters on average, low bailout stenting rate of less than 5%, good excellent safety profile, impressive efficacious results at 6 months, and a freedom from TLR of over 90%. However, we eagerly await the 1-year data, and we hope to report that soon. But things are actually very encouraging from this trial. Thank you very much for listening.
Congratulations. That's impressive data. We'll turn it over to our panel to now provide some questions to you guys.
So I'll start it off again because my last name starts with A. Very interesting data and great results. You have a huge population. The question is going to be, now the patients that I see with end-stage renal disease don't have those patent vessels below the malleolar area. So is this a different population with renal failure that you have in Singapore than we have in the US? Because that's one of the reasons we have kept them out of our trials, is that our dialysis patients tend to trim at the foot. So is this the same thing there, and this is a special population, or what is your feeling on that?
Unfortunately, I wish it was a very special population. It is not. We treat all comers, and unfortunately, the amount of renal disease is ever increasing. In terms of the below ankle disease, the inframalleolar disease, it represents about 20%, and we actually have to go in and treat that to get the outflow. So there's nothing special about that. Even if sometimes we have a lot of what we see, hibernating vessels below the ankle, and we just go for it. We actually have to go around the plantar arch maybe 15 to 20% of the time to get that outflow running. Unfortunately, a lot of these patients present with long, tibial lesions. We have to try and cross because we have to get a vessel down there. And a lot of these patients are not suitable for bypass, because they don't have any targeted vessels. But that's what I've noticed, having trained in the UK, then in Australia, and coming here. We don't just have those vessels here because of the calcification and the target lesions. So yes, there's nothing special about them. We just have to try and open them.
Thank you.
So I just wanted to ask, first I start by saying congratulations, really exciting results, always really fun to learn about new technology that's coming down the pike. If you could just explain, I know you said the nanotechnology that allows for these great results. How does this DCB compare to the other platforms on the market in terms of its ability to give off the paclitaxel or the drug and the other specifics, as much as you can share?
Thanks for that question. Actually, we're very fortunate in Singapore to have pretty much all the drug-coated balloons there. I've probably tried the majority of them in Singapore because it's easy to get easy access to them. I've used the Ranger, I've used the Medtronic balloons, the Biotronic balloons. And one thing I've noticed with this balloon, with the nanotechnology, is that the distal embolization or the slow flow phenomenon that you get is actually much less. And I was actually more confident putting this balloon down into the tibial when I was treating the lesions. Secondly of all, we also have the luxury of actually having access to the new sirolimus coated balloons that are on the market. And I must say it performed pretty much similar to those in terms of the flow. We've been using iFlow data to look at the flow phenomena with these two different types of balloons. And I must say that they are all different in terms of speed, in terms of what it causes to the flow rate of the foot. And I would say that the ivascular balloon is actually one of them that just doesn't cause as much slow phenomena compared to some of the others.
So I'm impressed at the high proportion of the end-stage renal disease patients, where we usually don't see those types of patients studied in the trials in the U.S. And how different was it to get these types of patients studied in Singapore, and how did you accomplish that? And how can you teach us to get that in the U.S. populations to better understand these technologies?
Thank you for that question. It's a very interesting question because all of these patients, we don't have a choice. Unfortunately, what we notice with these patients, especially PD patients and HD patients, actually slightly different as well in type of vessels that they present with. You get a lot of lumpy, bumpy disease with the PD patients, and sometimes they can be very challenging to treat with an angioplasty balloon. And typically, you're in the end of causing dissection and stenting. And where I've gone with those types of vessels is using an atherectomy device to actually reduce the pressure you need on the balloon to efface the lesions. In term, you may wonder why our 6-month results of primary patency are very different from the Singer-Packley study, which has caused so much issue regarding, to the BTK data from the recent meta-analysis from Katsanos, and it's become a primary patency of only 40%. But they excluded all patients with chronic renal impairment and only included ESRF. So you can see the difficulty that we face with these lesions, because the recall rate actually is much higher. And is that what we've done is that I've actually changed my policy and going to use what cardiology have done, and using high pressure non-compliant balloons for the pre-dilatation. And I think, as someone said earlier, I think we do undersize the vessels very much so, and using a long non-compliant balloon, I think will actually helps in this kind of scenario.
Any last thoughts or questions from our panel?
Can I ask a quick question?
Please.
I was curious, you had a high number of patients with severe calcium, and I was curious if you prepared them with what you said, with just a high compliant balloon, or if you used atherectomy in these patients, and how you prep to ensure the good outcomes from the drug-coated balloon.
Very nice question. As I said, I've actually gone from a policy over the last 4 years to go to I used the Jade balloon from Oberschnisch, the non-compliant high-pressure balloon, and I rack up the pressures to at least, can go up to 24 atmospheres for preparation of these vessels. I've seen a significant difference between using a semi-compliant balloon and a non-compliant balloon in our tibial vessels. And I think in order to try and get drug transfer properly, I think you really need to crack the lesion. In fact, recently I'm actually going down the use of using their CSI device to go down the vessel and actually prep that vessel better. But it is costly, because patients here actually have to pay out of their own pocket by cash for a lot of these devices, and it can get pretty expensive for a procedure. So we're very wary of that. But I think to get better vessel prep, I think it's very important, and I think it does tell with how you prepare the vessel and what outcomes you're getting.
Well, with that, I want to thank you, Dr. Tang, so much for presenting to us. Actually, being the furthest away and almost 12 hours different in time zone, and bringing us this amazing new data. With that,
thank you very much for the opportunity.
With that, I'd really like to thank my panel, both Dr. Ansel, Dr. Malone, Dr. Cohey, Dr. Beckman, and on behalf of VIVA Physicians, I want to thank the PIs and the companies that have been able to bring this late-breaking clinical trial data to us to be able to announce here live. And I want to thank everybody for their participation, and wish everybody a wonderful night.